Psoriasis has long been seen as a classic case of immune dysfunction gone awry, a misfiring of T cells, an overproduction of cytokines, and a hyperactive keratinocyte response that together turn skin into a battleground of chronic inflammation and rapid turnover. But what if the real troublemakers aren't just in the immune system? What if, beneath the plaques and redness, a quieter, stranger force is helping fan the inflammatory flames, senescent fibroblasts, the so-called zombie cells of the skin? It's a theory that's gaining ground, and with good reason. Fibroblasts, the structural support cells of the dermis, don't just sit there producing collagen and elastin. They also help regulate immune responses, influence keratinocyte behavior, and orchestrate the skin's healing processes. But when fibroblasts become senescent, especially under stress from chronic inflammation or environmental damage, they stop behaving like quiet background players. They swell, secrete pro-inflammatory molecules, and start to act more like dysfunctional immune amplifiers. And in diseases like psoriasis, where inflammation and barrier dysfunction are chronic and cyclical, this turns out to be a perfect storm. The key lies in the diversity of senescent fibroblast subtypes. Not all zombie fibroblasts are equally inflammatory or equally destructive. Some release a relatively mild SASP, focused on extracellular matrix remodeling. Others unleash a biochemical riot. IL-6, IL-8, TNF-A, CXCL1, CCL2, MMPs, molecules that draw on immune cells, break down tissue, and keep the cycle of inflammation going. In psoriatic skin, which is already swimming in immune signals, the presence of highly pro-inflammatory senescent fibroblasts could act as accelerants, maintaining the local inflammatory loop even in the absence of external triggers. Emerging studies using single-cell transcriptomics and immunostaining have started to reveal that psoriatic lesions show not just an increase in senescent markers like P16-INK4A and SASS-Gal in dermal fibroblasts, but also a distinct senescence-associated secretory phenotype that overlaps with key drivers of psoriasis pathology. These zombie fibroblasts aren't just old, they're strategically problematic, releasing exactly the kinds of signals that attract Th17 cells, activate keratinocytes, and disrupt skin barrier repair. In this way, they may function as hidden instigators, keeping the inflammatory fire burning between flare-ups. There's also the question of how these cells persist. In healthy skin, senescent cells are usually cleared by the immune system within days or weeks. But in psoriatic skin, the immune environment is chaotic and often skewed toward dysfunction. Chronic cytokine exposure, especially IL-17 and IFN-, can impair macrophage function, disrupt clearance pathways, and even induce more senescence, creating a feedback loop. Add in oxidative stress from scratching, microbial imbalance, and systemic metabolic factors, and you have the perfect conditions for senescent fibroblasts to thrive where they should not. This opens up a provocative line of inquiry. Are these senescent fibroblasts not just consequences of inflammation, but active participants in its persistence? If so, targeting them could offer a completely new therapeutic angle. Instead of only trying to modulate immune cells with biologics like TNF or IL-17 inhibitors, what if we added a layer of senescence modulation? There are a few potential approaches. Senolytics, which selectively kill senescent cells, could be used topically or systemically in psoriasis patients with high senescent burdens, especially during remission to help prevent flare-ups. Xenomorphics, which suppress the harmful secretions without killing the cells, could calm the inflammatory contribution of senescent fibroblasts without impairing wound healing or dermal integrity. Even immune-enhancing therapies that improve the skin's ability to clear senescent cells naturally, perhaps by restoring macrophage or T-cell function, could reduce the zombie load without introducing new drugs. More speculatively, diagnostic tools that assess fibroblast senescence patterns in lesional versus non-lesional skin could help predict disease severity, chronicity, or response to therapy. A skin biopsy showing a high load of pro-inflammatory senescent fibroblasts might indicate a need for combined immune and senescence-targeted therapy, while a more fibrotic senescence pattern might call for a different strategy altogether. Of course, we still have a lot to learn. The causality isn't fully established, and it's possible that senescent fibroblasts are passengers rather than drivers in some cases. But there's spatial correlation with inflamed tissue, their SASP overlap with psoriasis-related cytokines, and their known effects on immune recruitment and tissue remodeling all point in one direction: They're not innocent bystanders. So yes, psoriasis may be an immune disease at heart, but it increasingly looks like a stromal disease in disguise, where senescent fibroblasts are quietly scripting the flare-ups and making remission harder to hold on to. If we can find ways to listen to these zombie cells, classify their intentions, and intervene before they destabilize the system, we might just turn down the volume on this lifelong condition. In doing so, we wouldn't just be treating the immune system, we'd be editing the inflammatory script at its cellular source.